So today we're going to discuss a little bit of the anal rectal anatomy. And one of the things that I found is that in order to understand this last 5 to 10 centimeters, sometimes you need to visualize things. And the best way that I've known over time is to basically think about yourself getting shrunken down and inserted into the anal rectal anatomy. And you're this little tiny person and you're walking around, and what's around you and what are you feeling? And so it's the little man in the anal rectal anatomy. So when you think about the last 5 to 10 centimeters of the GI tract, one of the things that you have to think about is there is a lot going on in here. And a lot of people think about it just like this, a tube, nothing more than a tube. But there's so much more, and I always say that the anal rectal region is one place where the anatomy truly guides the pathology or the pathophysiology behind it. So pretend that you are shrunken down and you are sitting right there. You're about ready to dive in. So we're going to go over some terms and we're going to be able to say, what is it? What am I looking at? And again, you can read anatomy textbooks and then this clinically, like, what are you looking at? And think to yourself. So if I was to shrink you down and I was going to place you right down there, one of the first questions that comes up is, where is the anal verge? If you take a look, you'll see, let me just draw this in here first. If you take a look right around this area, right at the opening of the anal rectal region, you will see a small area, and I'm going to turn it here at the anal opening. Here's the anus sitting right here, where the shiny appearing skin, if you will, meets normal looking skin. And if you really look closely in a human, there's a little area around where you have hair-bearing area, and in between the hair-bearing area and the anal opening, there's no hair. So this is where we get into the stratified squamous keratinized epithelium versus non-keratinized epithelium, and then whether or not you have glands. And the reason that comes into play is you have to think to yourself, if something, for example, you thought involved a hair and an ingrown hair, like a polynidal or something like that, you would think the closer you get to a non-hair-bearing area, that's probably not going to be a polynidal, even though a lot of these things can look a little bit different. So this area down here, where the normal, quote-unquote, appearing skin that you see elsewhere in here, versus that shiny appearing skin, that area is called the anal verge, and you're sitting right at the anal verge. Now let's just say that you were going to walk around this way. You're going to walk this area around. And again, kind of flipping this up on its end and seeing this area. There's about a bullseye region, about 5 centimeters in every direction. And that particular area is called the anal margin. Now, in the past, so that's your anal margin. Now, in the past, you know, one of the things that we talk about is, okay, so who cares? Why does it matter anything? Well, one of the things that we know is that if you would have a tumor, let's just pick a tumor right here, and let's put it in the anal canal. So here's my tumor in the anal canal, and I'm staring at that tumor, and it's a big, bulky tumor right there. Well, back in the 1970s, and earlier than that type of tumor would need to have all of this taken out. That's an abdominal perineal resection. But Dr. Nigro in the late 70s on studies of 3 patients was his original description, talked about treating these squamous tumors with chemoradiation therapy, the so-called Nigro protocol. And what that particularly does is it has non-operative therapy. Well, discriminating the anal canal tumors with the anal margin tumors, if you'd have small lesions that are out here, and again, I'm not trying to get into weeds because there's a lot of weeds that would go into this. Many of these areas on the anal margin can be treated just like skin cancers elsewhere. And in many cases, those can be treated with just resection alone, making sure we have proper margins and proper staging and proper everything. Now, the weeds is that there are some anal margin tumors that will get chemoradiation therapy, but it's important to understand the margin is the area around it, and again, the anal verge is sitting right in this particular area where the shiny skin meets the kind of quote-unquote normal appearing skin. So let's get rid of our anal verge, and let's have our guy. So our guy was walking this way, walking that way, that's the anal margin. I'm going to take away this guy for 1 second real quick. And now it's time to walk in and get into the actual anal canal. So here I am. Now I'm just going to go inside. So we just stepped right inside of, smiling, I'm just inside the anal canal. Now, picture yourself, you're in the anal canal and you're in basically a tube and you got walls all around you. So the area that is in between the anal verge, and this little purpley hueish line right there, that is called your dentate line. It's typically about 2 centimeters in, or your pectinate line. You're up, you're grabbing on, this little guy's grabbing on right here, grabbing onto that dentate line, our arms are getting extended, and I got my feet on the anal verge. This lining, remember I'm not a great artist, but this lining that's all the way around is mucosa of the anal canal, of the distal anal canal. And what I'm touching, as I'm touching right around this, in this case he's hanging on to the dentate line, but if I was to then reach out and touch any of these walls, that's what we call anoderm. And so we hear that term a lot, and what does it mean and why is it important? Again, going back to how some of the aspects that we do clinically or surgically really go back to the anatomy, is that this is the area that has a lot of sensation to it, right? So we want to make sure that we have good sensation. For those of you who are a little bit older, I used to say that the anal canal is always the Rodney Dangerfield of the body, gets no respect. If you have no idea what I'm talking about, Google him. He's a comedian. He always would talk about, I get no respect. The anus gets no respect. But in a matter of seconds, it can tell the difference between, I got to go now, I got to go right now. Is this liquid? Is it solid? Is it gas? What am I dealing with? And so we want to preserve that anoderm. So you can imagine very quickly, again, going back to this area, let's just pretend again that we had hemorrhoid disease. So let's say you have your classic hemorrhoid disease, your trifecta, and in this case I didn't draw it well, but we'll draw it even better, and we'll just say that as we're looking at it, we have a left lateral, we have right anterior, and we have a right posterior. Let's just say we have that, even though when you look at this isn't always, true to form. So if you were to do a 3-column hemorrhoidectomy, and remember the hemorrhoids are things that would prolapse out from here. If you would do a 3-column hemorrhoidectomy, in the old days, they would strip all of this area, and you would have a stricture in that area. You could get what's called a whitehead deformity. You could still perform a safe hemorrhoidectomy, and even a 3-column hemorrhoidectomy, but you got to be conscientious of essentially allowing yourselves the opportunity to leave enough anoderm, so in between each of your resections. So this is the anoderm that we're talking about as you're doing your hemorrhoidectomy, and we want greater than 1 centimeter of anoderm left in between each of your columns if you're going to do something like that. So again, understanding hemorrhoids, but it's beyond hemorrhoids. It's that anoderm, what is its function, and then how do we treat those patients? And we got to start to think about not necessarily how much you're going to take out, but how much anoderm you're going to leave behind, so you don't get strictures, you don't get stenosis, you don't have that loss of sensation that's problematic. Back to our little guy. So now, I'm still standing right there. So Shreya's behind the camera. So Shreya, what am I standing on right here? The anal verge. What am I grabbing onto?
The dentate line.
Grabbing on the dentate line. So now, and I got anoderm all around me. So now I'm grabbing onto that dentate line. So now it's time to say to ourselves, what is the dentate line? And why does it matter? Well, it's a lot of different reasons, but let's go back to thinking about how clinically this matters to us. So we just talked a little bit about hemorrhoids as an example. So we know that hemorrhoids can occur from above, around, or even below the dentate line. Remember, hemorrhoids serve a purpose. They're that last little stopgap to kind of collapse the tissue so that we don't have leakage or seepage. Well, we know from embryology that this area down here is essentially innervated like the skin out here. So if this little guy is touching the skin, the person who this is can feel that, just like it's on the skin, because that's somatic innervation. Versus above the dentate line, when you're higher up, not only does the histology change, and I'll get to that in a little bit, but the innervation changes, and that innervation becomes something that's more like autonomic. Well, who cares? Well, just think about it. One of the ways that we treat hemorrhoids, for example, is essentially cutting them out, as I just showed you a little bit ago. And another way that we treat hemorrhoids is banding. So let's just take our sample here. So here's our dentate line, here's our little guy, and I'm standing down here. And I reach out and I got my hemorrhoid bander, and I got a hemorrhoid right here, and I put a band right around that guy. I grab that and I put a band around. What does the patient feel? Well, because it's somatic innervation, just like you would feel elsewhere, you might as well put a rubber band on your pinky and then just cause the blood supply to decrease your pinky, because that's really how hemorrhoid bands work. And so doing that below the dentate line is not the way to go because a patient will have severe pain. But an autonomic innervation, if I then walked up a little higher, now I'm sitting up here, and I took that same hemorrhoid bander and lassoed a giant hemorrhoid that's in there as I lassoed it in there. Now, I don't get that sensation. I may have a deep pressure maybe right in the beginning, but I don't feel that sharp pain that you would feel just like if you put a band around your finger because it's a different anatomy. I'm standing above the dentate line. So one of the things about the dentate line is distinguishing between, again, having somatic innervation, and having autonomic nervous system innervation up above the dentate line. Again, we know the autonomic nervous system does a lot of different things in the body, but in terms of the anal canal, that's one of the things that it does. So again, the concept that we were talking about before, how does the anal rectal anatomy guide how we treat our patients in terms of pathophysiology? So let's take our guy back out of here and let's go back below and let's have him stand up here at the dentate line. Okay, here we are. So here's our little guy and he's standing at the dentate line. Now I'm standing on the dentate line. So what is this dentate line? Well, first of all, what does it look like? Well, it's typically kind of a bluish, purplish hue around that area. And at the bottom of each of these little areas of the dentate line, those are things that are called crypts. And you have, over here, you have glands. And essentially, if I was to get into one of these and I was to kind of swim all the way around here and I find myself sitting over here in one of the glands, the purpose of these glands are to make mucus so that we have lubrication, so that when we're having bowel movements. Well, again, what's one of the problems? Let's say that, again, I took a swim and I'm going in there and I get stuck right in the middle. There I am. I'm blocking off that canal from the gland to the crypt. What happens? I get pressure, I get pressure, I get pressure, and that is what forms what, Shreya?
An abscess.
That's an abscess. So again, the cryptoglandular theory of anorectal abscesses, about 80% of abscesses are from the cryptoglandular, from blockage of these. So my little swimming and getting caught in here causes backup to this. And abscesses in the anorectal region are essentially defined by location, versus fistulas are defined by their relationship to the sphincter. So let's see, what does that mean? Okay, so I'm going to use an example over here. Let's just say that here's our muscle. So there's two muscles that are kind of predominantly down there. And then again, the muscles, as we go up higher, they'll go into the levator floor, and I'm going to kind of ignore that for right now. But we have two muscles. An inner muscle, which is called the internal anal sphincter, and an outer muscle called an external anal sphincter. So as you're sitting there watching this particular video, each of them do provide some degree of what we call resting pressure, so the anus stays collapsed when it's in there. The internal sphincter provides about 80%, the external sphincter about 20%. But when you're like, God, I'm sitting in class, or I really got to go to the bathroom and I don't want to go right now, and you start to squeeze like crazy, that's your external sphincter muscle. So the internal sphincter muscle is smooth muscle. The external sphincter muscle is skeletal muscle. Who cares? Well, I already told you that one of the reasons we care is the degree to which you have the ability to either squeeze down or to allow it to have resting pressure or resting tone that's there. Well, one of the other reasons is, again, let's go back to this concept of how you have pathology or pathophysiology dictated by anatomy. So let's talk about a condition where these two muscles right here are too tight. And when they're too tight, you can get a problem, typically in the posterior or the anterior midline, of a crack. It's got rolled edges and a pile to it. And you can see invisible internal anal sphincter muscles, and that condition is called a?
Anal fissure.
It's called an anal fissure. And so think about the different ways of which we treat an anal fissure. Well, some of them are surgical, right? We talked a little bit about the ability to come in here with a knife, access this space, the intersphincteric space. If I'm the little guy now standing right in here, I'm standing in this particular space, the intersphincteric space, and I can take a machete, boom, I got a machete here, and I chop off a portion of this bottom part of this. I slice it right through there. What did I just do? If I do it on the lateral side, that's what a lateral internal sphincterotomy is. I don't want to lance it all, and I certainly don't want to come on here, but if the muscle being too tight is a cause from this, we need to relax the muscle. So you can do it mechanically my little guy here taking a swing and chopping off some of that muscle. We talk about dividing a third of the muscle and some of these other things, or divide just the bottom part of it. Do you divide up to the level of fissure? Do you divide up to the dentate line? And you can read all about that in different textbooks, the degree of which you do a lateral internal sphincterotomy, but that's the area of what you do. You come right in here and you can either make an incision out here and dissect down, or you can put the knife in here and divide this lower part of the muscle. That's lateral internal sphincterotomy. Or the other thing you can do is take a look and say, what do we really want to do? Well, what we really want to do is we really want to have the areas relax. So if you're going to relax, one of the things we want to take care of is we want to take the properties of this particular muscle and we want to get to relax. So it's smooth muscle, and this is where we look at having all the different smooth muscle relaxants that do it. So whether you talk about nitrogen or nitrous oxide, glycerol trinitrate, diltiazem, a calcium channel blocker, or nifedipine, all these different ones. There's all sorts of things that will be out there, but they all work by essentially just saying, I want to relax that smooth muscle, or even Botox, and talk about acetylcholinesterase and all the different activities of what we're trying to do to allow us to allow that to relax. But we're taking the intrinsic muscles in order to see how we can have anatomy and pathophysiology create. So I'm going to take care of this abscess, and we're going to talk a little bit about abscesses in relation to there. So we talked about a cryptoglandular theory. I talked about how it becomes blocked. Again, not every abscess is from that, but about 80% as we like to think of them. And just drawing our dentate line again. This is not to scale. Let's go back to kind of what we're dealing with. Okay, so the glands can be kind of over here, and then we talk about the different areas of which abscesses can occur. So now, let's talk about this. So here's my little guy. Sorry, let me just finish this in here. Okay. Just draw our muscles on this side. So there's different spaces in the area, and all these different spaces are ones of which that abscesses can occur. And remember, I talked earlier before how a fistula in the anorectal region is always in relation to how it goes and traces the course of the sphincter muscles, versus an abscess, it's just the space itself. So in this case, you can have a submucosa or superficial or perianal abscess. You can have an abscess that lies in this space right here. This is called an intersphincteric abscess. And then you have this giant space over here that sits. You have bone on this side and bone on this side, and you have this space where abscesses can occur. Do you remember what that's called?
The deep anal space?
Yeah, yep. So the deep anal space is the connection that can occur between these two spaces, but this particular space here is our ischiorectal fossa. And so exactly what you said is that you have this, on your body. If I was to kind of come down here and I was going to say, okay, I'm my little guy and I'm hanging out in all this fat. My levators are up here. Eventually, as this goes up, the internal sphincter muscle becomes one of the wall muscles of the rectum. This comes up, the external joins are levators. And essentially, I'm a little guy and I want to think about the anatomy and where these abscesses can occur. So here's my ischiorectal space. Here's my ischiorectal space. We talked about the different abscesses, perianal, the intersphincteric abscess. One of the abscesses that can occur is above the levators up here. So that's a supralevator abscess, it's above the levator muscles. But now let's talk about one of the more complex ones, the ones that you talked about, and that's that deep postanal space. So now I'm a little guy, and I say to myself, I'm hanging out here in the ischiorectal fossa where an abscess can occur. Let's just pretend, for whatever reason, that my buddy was hanging out over here, and I wanted to go visit my buddy. How do I get over there? Is there a way that I can get over there in the human body? Well, we already said out here, if I walk lateral in this space, what am I going to run into?
The ischium.
Yeah, I'm going to run into the bone, right? The bone's hanging out there. So I can't go that way. So I got to be able, if I walk straight into this area, what would I run into? I'd run into muscle in that particular area. But there's a defined tract that goes from one side to the other in a space that is below the levator that's a tract behind the rectum that allows you to connect from one side to the other. And it runs through that deep postanal space. And one of the classic questions is, what are the boundaries of the deep postanal space? And this is one of the places where an abscess can occur. And you classically see drainage from the posterior midline at the anorectal region. So again, I didn't draw this exactly to scale, but again, you get the hint that this is going around the rectum. So now, I'm gonna start walking. I'm gonna start walking. Here I go, here I go, here I go. Let's just stop right here. So now I'm your little guy, and I'm in my deep postanal space. And I'm in the midline back down there, and I gotta say to myself, okay, what is my ceiling and what is my floor, and how am I getting in there? Well, in the back on the posterior aspect, what am I standing on in order to get into this area? And again, I want to ensure, look at it, I'm not an artist, that's my disclaimer. This is not to scale and it's not drawn exactly, but you got to say to yourself, how do I get in there? What is my ceiling? What is my floor? In my floor is what I'm standing on is in the anococcygeal ligament. That is a ligament that we oftentimes need to divide in order to be able to get ourselves into access to that. If you look up the Hanley procedure, the modified Hanley procedure, you hear a little bit more about it. It's also the area of which we're doing an APR, that you feel and divide that anococcygeal ligament so that you can get in access into the the extraperitoneal, but into the pelvis in order to conform, in order to take all this area out. But what is my ceiling? Now I got to say to myself, what is my ceiling? What is above me? I'm walking along this space. My little guy's walking along because he wants to see his buddy over here on the other side. What is my ceiling? So the ceiling that I'm feeling up on and I'm pressing up upon is the levators. So now I'm pressing up against levators. So your tunnel from one side to the other is that area along that deep anal space around the rectum, where you go to ischiorectal fossa to ischiorectal fossa, and as you walk along, you press it up against the levators. And the important point is to understand is that that's that space in between the levators and above the levators is a different type of abscess. I already talked about that before. That is your supralevator abscess. It's above the levators, and oftentimes, again, a supralevator abscess can occur from multiple different sources. It's in between that, and then it's apart, separate from some of the lower abscesses, whether they're intramucosal, intrasphincteric, ischiorectal, or perianal down there. So think about, you want to visit your buddy on the other side. How do you get there? You get there through the deep postanal space. What is your floor? What is your ceiling? So now let's briefly, very quickly talk about fistulas. So fistulas can occur anywhere between 30 and 40%, depending on what you see following a standard one. And we're not talking about a Crohn's fistula or anything right now. I don't want to get into the nuances of this. Let's just talk about fistulas and how they relate. So we know that we drain that, and unfortunately sometimes it doesn't always heal in. So in this particular case, we've got our muscles again back here. I'm going to get rid of this abscess. And if you really think about it, if we know already the underlying pathophysiology, and now we know that it's in relation to the sphincters themselves, and we know that about 80% of the origin of the cryptoglandular lesion, now you can start to say, okay, this is going to make sense. So let's just say that I'm this little guy, and I am going to walk along a fistula tract. And that fistula tract goes, boom, out to there. And I just start walking. Think about what you're passing through. Remember, a fistula is a fancy word for a tunnel. It starts at one place, goes to another. It's a fancy tunnel. So as I'm walking right here, I'm walking. What am I crossing right here?
The internal sphincter.
Now I'm
muscle.
walking. What am I crossing here?
External.
And I wound out to the end. What type of fistula is that called? That is crossing your transsphincteric fistula. We're going across both of the fistulas. Should make sense. Now, same guy, different tunnel. Now let's just say that this one kind of comes like this. I drew this a little bit wonky for practical reasons. Let's just give it here just for my own art. Let's just say that tunnel goes there and then down. So now I'm a little guy, and we're walking, and the first thing I come across, I'm walking, what do I come across?
The internal sphincteric.
Then where do I go into here?
The internal
intersphincteric
intersphincteric
yeah, you're
groove.
right, intersphincteric space, and then it goes down to the skin. What type of a fistula is that?
The intersphincteric fistula.
Boom, in relation. So it goes in the intersphincter space. It's not going all the way across each of them. And so you can imagine, based on what some of these are, that if you have something that avoids the muscles altogether, that's where you call your extra sphincteric fistula. Or if one comes in, and I'm walking, it goes up, over the levators and down, where it does cross some of it, that is your suprasphincteric fistula. So think about what this little guy is going to do and where they're going to walk. Are they going to walk across both of them? Are they going to walk across one and then go down? Are they going to walk in between and go up over? Are they going to avoid those sphincters altogether? And you can imagine as we start to get higher, or a high transsphincteric, or whatever path this crosses, you have to be aware that if you're going to do a fistulotomy, which is cutting and flaying that area open, that potentially that you now start to think about, am I cutting too much sphincter that it gets complex? And that's where things like setons come into play. That's where things like flaps come into play. And again, this is not a message or a lecture on any of those. It's just simply on saying you have to be able to think about how we treat certain diseases goes back to the anatomy of this wondrous last 5 to 10 centimeters of the human body. Okay. Well, I think that for part 1 at least, we'll end off right here. Hopefully, again, you'll understand the rationale. Think to yourself, because a lot of people view it as that too, but what I really want to get you to think about is shrink yourself down. What am I looking at? What am I feeling? What tunnel am I walking along? What's my floor? What's my ceiling? What's around me? And then most importantly, go back and say, how does that anatomy that I'm dealing with clinically affect the way that we treat these patients, that we can treat the underlying condition and not do them any further harm? So until next time, dominate the day.